let me thank all of you for being so supportive and continually coming and hopefully learning something about various health education issues. Today, as for our anniversary, and now soon I'll bring out the cupcakes. But I know I was trying to let Dr. Kretchman think that we only had healthy stuff. And I know she knows a lot of you, so she knows the real truth. But first of all, I want to thank her for being here, as well as for your last minute needing information for your Medicare choices. Terry Ham is here with us again. I know a lot of you have already been to check with her, but please make sure you do check with Terry. You might qualify for the Q&B program, which is basically you're getting that Part B will be paid for. Was that like $137 approximately? So make sure to check to see if you would possibly qualify for that program. And also we want to thank WCTV. So I have to let you guys know you'll be on WCTV. So and also we're going to start before we get started. Who has 651-413? And we have a lot of really good prizes today. We have some donations from Vicky Tate's Paparazzi, as well as Katrina Orr has donated some goodies as well. So, and we have our grand prize today will be a nice gift basket from the Reid Health, in addition to the $25 gift card. So your odds are pretty good today. So now, I want to, without further ado, Dr. Erica Kretchman, and she's with Reid Endocrinology. Dr. Kretchman also just did a live improv performance a couple weeks ago in downtown Richmond. So I told her improv has nothing on the Medical Monday group. So.
All right. All right, so if you guys throw out random things, that means I have to respond to it. That's all improv was. They would just yell, "Be a giraffe," and I'd have to do it, but please don't. Is my voice level okay for everybody? I want to make sure that we can all hear. And if it's not in the back, I'm usually really good at projecting. Just please raise your hand and let me know. So November, I feel it's special to be here. November here is American Diabetes Month. So I know that you guys had my partner, a special, another endocrinologist talk last year. So I was excited to have the opportunity to meet some new faces and see a lot of friendly faces here. As an endocrinologist, I do specialize in the management of diabetes. This is probably what I do most of every day, is about 60% of what I see. And it's also something that I love and I hold near and dear to my heart. I, as an endocrinologist, has lived with diabetes for 25 years. So how many of you out there, you don't have to raise your hand if you don't want to, but just if you or someone you love is affected by diabetes, raise your hand. Great. I say great. I think that's just kind of how I've approached it in my life. It's unfortunately a very common thing. And I hope that you're here to learn, and I hope that you're here because you know that this disease, although it's difficult, is something that we can manage and we can overcome together. So speaking of things, I have a little bit of something at the end of the talk, but do you guys see these things here on the table? So 2 days from now, it sounds like you guys are excited to learn, and it sounds like you guys like to get door prizes and free food, right? Free food. So on Wednesday, at Lingle, we have our 13th annual diabetes event. And it's from 5 to 7, so you come at 5, there's hors d'oeuvres, and then we have a speaker presentation. We also have somebody who has had diabetes for 50 years, so I can learn a lot from somebody who's had diabetes for 50 years. And then we'll have a panel of experts. Unfortunately, you'll have to hear me talk because I'm the MC of the event. But we have our other endocrinologist, Dr. Tim Haney, a cardiologist, Dr. John McGinty, an ophthalmologist, Dr. Travis Cates. We have a foot doctor, Dr. Bill Spiropoulos, and yes, I can say his name if you see Dr. Bill. And then we also have our kidney doctor, Dr. Dowd, that will be, did I hit, and of course Dr. Tamhani, if I said them all. I feel like I'm missing someone, but yeah, that will be our panel of experts. So they're going to talk to you a little bit about their role in diabetes, and we're going to let you ask them all your questions. So start thinking about what you would like to ask them. How many have registered for it already? Good. How many would like to register? I love it. So I am going to, while we're talking, I was supposed to get a fancier sheet from the girls at Diabetes Education, but I just have a blank sheet. I will just start passing, everybody pass it around. Even if you're not sure if you can come, sign up because it helps with food count. And if you don't have diabetes and you want to come. It's a good chance to learn. Yeah.
I just want to add, when she says the hors d'oeuvres, they are amazing.
They're good, yeah.
They're very more heavy hors d'oeuvres. So.
Yes, right. You can make a meal out of it, and they have all the carb information. There's also a dessert afterwards. I saw the cupcakes. I don't know that it's going to compare carb-wise to the cupcakes there, but hey, it is our right to have in moderation our dessert. So we are going to talk about today, I put a presentation together because one of the focuses of this month is diabetes and heart disease. So this is the topic that I thought we could talk about or present today. So what exactly is diabetes? We hear this word all the time. Would anybody have an idea of what they would say diabetes is? Anybody want to be brave and shout it out? It's okay if you don't feel it. Okay, that's all right. I'm all right with that. Diabetes is such a common thing that I think we all get so familiar with it that we forget what it actually is. So diabetes is a disease where you cannot regulate glucose and insulin. So when we're eating, even these salads, your body takes the nutrients that you eat and they turn them into sugar in your body. For the body to use sugar, because we use it for energy, it needs insulin. So insulin acts kind of like a doorman to get glucose into the cells so it can be used for energy. So I put up here these two little cartoons, the G, the glucose, and the I, insulin. How have you guys, is all diabetes, is there just one type of diabetes out there? No, right? There's multiple types of diabetes. How many of you, if you know or your loved ones have had diabetes, have ever been confused about what type of diabetes they have? Anybody? You guys are all pretty familiar with it? That's awesome. So for those out there in TV land, I wanted to put up a little bit of what are the main differences between our two big types of diabetes. So when we look at diabetes, we generally divide it into two categories, type 2 diabetes and type 1 diabetes. So type 2 diabetes is our most common form. This is about 90% of the diabetes that we have in the world is type 2 diabetes. And this is characterized by insulin resistance. So what happens here is the body still makes insulin, but it doesn't utilize it. It's resistant to it. And we'll get a cartoon about that insulin in the doorman that explains that to you. So either they don't use it well, and then the pancreas stops making it well. So a lot of times people with type 2 diabetes may use lifestyle modifications, oral medications, and even insulin to help control it. Type 1 diabetes, which is about 5% of the diabetes that we have, is an autoimmune condition in which the body destroys our insulin-making cells. If you don't make insulin, you cannot have energy. So this type of diabetes are the people who have needed insulin for their entire life since diagnosis. So then if they don't have insulin, they can have a life-threatening condition called diabetic ketoacidosis. Now, these aren't the only exclusive types of diabetes that are out there. Some people may have diabetes that are induced from medications. Steroids, right? I know steroids have affected some people's blood sugars. Even some chemotherapies that we have can cause diabetes. Sometimes we have diseases of the pancreas itself, maybe pancreatitis or inflammation, surgery, injury. These are also things that can cause diabetes. So in the world, it's not just type 1 and type 2. There are many different causes of diabetes. So let's look at this cartoon to help illustrate it or understand it a little bit better. So we have our G for glucose and we have our I for insulin. So let's pretend that this wall is our cell. Cells have walls, right? And glucose on the outside needs to go inside the cell to make energy so we can function, we can think, we can move. So insulin is our doorman. If you don't have problems with insulin resistance, you don't have a problem with diabetes, insulin can just say, hey, come on in. And glucose travels easily into the cell. Okay, does that make sense? When you have type 2 diabetes, You make insulin, but that door is resistant, insulin resistance. So insulin's pulling and trying to get that door open, and maybe a little glucose guy like squeezes through, and you get a little bit of energy from your glucose, but most of the glucose is stuck out here, which we would represent as this being in your blood. So this is why our blood sugars are high, because instead of getting pushed into the cell, most of them are staying out here, okay? So sometimes we can use medicines that would target this insulin resistance or make the door easier to open, or medicines that can help get more insulin into the body, okay? So that's type 2. This is our most common cause or type of diabetes. And then this cartoon is going to illustrate type 1 diabetes. So this is the autoimmune diabetes in which the body has destroyed your beta cells. So what is missing from that picture? We got our G, but what don't we have? Our I. So we don't have insulin. So without insulin, the glucose is like, hey, we know we need to go in there, but nobody's there to open the door. So that's kind of a cartoon to help explain a little bit of the difference. So this person, there's no medicine to improve insulin resistance, because if there's not insulin there, it doesn't matter how easy the door is to open. People with type 1 diabetes need insulin from the get-go. So the burden of diabetes, I think it's important to talk about statistics, because diabetes is one of these conditions that continues to rise. Right now, it's estimated to affect about 9% of adults. And in the United States, the last time they looked at it through the CDC, which was, I believe, 2015, it was 30.3 million, or 9.4% of the US population has diabetes. And this map kind of shows us the estimate, and this is in 2014, of adults with high fasting glucose. So this is including other people with just raised fasting glucose, not just diabetes. But you can see it's not just a US problem, it is a world problem. So diabetes isn't just about blood sugars, but it's about controlling the blood sugars to reduce the risk of complications. When we talk about complications from a diabetes standpoint, you know, as a physician, I gotta be fancy. I gotta use big words to sound like I'm smart, right? So we divide it up into microvascular and macrovascular complications. Does that sound fancy, right? Yeah. I'm smart. It literally just means micro, little, right? And macro, big. So when we talk about microvascular complication, these are our small vessels, okay? And these are probably the things that you may, being a person or loving a person with diabetes, may be familiar with. Our small vessel complications are our eyes. So diabetes can damage the eyes, and it can cause injury to the blood vessels. It can cause what's called retinopathy. Retinopathy is when those vessels are leaking in the back of the eye. Maybe you need laser therapy or injection therapy to control it. It can also cause cataracts, and it can cause glaucoma. And in fact, diabetes, unfortunately, is the leading cause of blindness. Kidneys. Kidneys are small vessels, very similar to the size of the vessels in the eyes. So people who struggle with diabetes damage to their eyes oftentimes will struggle with some diabetes damage to the kidneys. So they will damage, the high sugars are very toxic to those vessels. It'll damage the vessels, and it'll cause the kidneys to have to work harder, and it'll cause protein to leak into the urine, which continues to damage our kidneys. And in fact, diabetes is right now the leading cause of dialysis in the United States. And then the last thing is the neuropathic pain. You may not know what this little thing is, but this is a bundle of nerves. So diabetes can affect and damage our nerves. And this is often the most distressing thing, because until the eyes and the kidneys are at that later stage, you may not have a lot of symptoms from it, which is why you need to make sure you get your blood test done every year. You need to get your eyes examined every year, because you can prevent it if you catch it early. But the neuropathic pain can sometimes happen at diagnosis. And this could be something that they're just numb. You don't feel them. This could be something that they feel like you're walking on coals. It could feel like someone is stabbing your feet. This is a very distressing problem. And since you don't necessarily feel the sense of pressure or pain, you can injure or damage the shoe or your feet simply from wearing a new shoe, or simply from having a little pebble stuck in your shoe and not knowing it, or walking outside barefoot and having an injury. I've had people step on nails and not know that they stepped on nails, walk on a nail for 12 hours. But this is what diabetes does to your small vessels or your nerves. And this, unfortunately, leads to loss of toes and limbs, and is really the most common cause of amputation. Thank you. I heard some words. Do I get to pick a bag by who volunteers the most? Yeah. So I always. What's that? Okay. As a person, not just treating diabetes, but living with diabetes, I always kind of hate saying these things. It's the leading cause of this. It's the leading cause of that. Because one thing when I was diagnosed with diabetes so many years ago, I almost just said like, well, I guess I'm going to lose my limbs. I guess I'm not going to see, and I'm sure that everybody here who walks with diabetes has felt that at some point. But I always want to say this out there because these are just statistics. We are the people, right? So we don't have to be the people that are struggling with these complications if we control our blood sugars. And that's a part of the reasons why I'm here as an endocrinologist in this community, because I'm passionate about helping people not have these complications. Or if they have happened, trying to reduce the risk of them getting worse. But let's go on to kind of what we want to focus on is the macrovascular. And macro means big, right? So these are big vessels. We know our heart is a big pumping machine, right? Unfortunate big complication from diabetes is that it can also cause damage to our big vessels in our body, which are the vessels that come from our heart, the vessels that go up to our brain, and even into our extremities. So not only can we have that nerve damage, but we can have blockage in our extremities. So this increased diabetes causes an increased risk of stroke, of mini strokes, of cognitive impairment. In the heart, the high blood pressure and the insulin resistance can cause increased risk of coronary artery disease, which means blockage. And in the extremities, it can narrow our blood vessels, and it can cause lack of blood flow in the legs. And this also is a part of why we see amputations, is that wounds don't heal well because they don't get blood flow. So what exactly is cardiovascular disease? So again, remember, I know that this is doom and gloom and we're talking statistics, but we're not statistics, we're people. Cardiovascular disease is a leading cause of death among people with diabetes, yet much of the population is unaware of the risk. 75% of people with diabetes will have heart disease. This breaks my heart. And in fact, last week or a week before that, I had a patient who I was seeing for prediabetes, which we'll talk a little bit about. And she was talking to me about her brother who had a sugar of 700. Who would say that's bad? Right? Yeah. And when he went into the emergency room with a blood sugar of 700, he also had a heart attack. Right? So she was saying, yeah.
I know somebody that had a blood sugar of 1,400.
Okay, 1,400 in the emergency room. You're looking at someone right here at a blood sugar over 12,000 when she was diagnosed. I'm sorry, 1,200.
Okay.
Yeah, sorry. Edit that, please. But it's dangerous. I was definitely very near death when that happened.
What made you?
Honest to goodness. So I was 15, turning 16, and it was a summer. So I was away from my house going to camps like band camp because I'm a nerd, music camp. Yeah, nerds, all right. Drum major camp. And then for my 16th birthday, my sister took me to a sweet thing called Woodstock 1994. It was the 25th anniversary. I know some of you may have been like, I could have been at the original one, Dr. Kretchman, you're not cool. So I thought that whole summer it was hot and I was drinking a lot because it was hot. I was losing weight, but a 15-year-old girl with losing weight was pretty happy about that. It didn't depress me too much. And I was peeing a lot, but I thought, gosh, I'm drinking a lot, so I'm going to pee a lot. So, and I was not away. I was away from home. I was away from my parents. So they didn't really recognize I was there, and then I went to the next camp, and then I went to the next camp. And then by the time I went to Woodstock, I started to feel very sick. And I was a good kid. I swear. TV, I swear. I'm a good kid. I'm a good person. I never drank. I never smoked. I never did drugs. And when I went to Woodstock, I was like, oh, is this a contact high? Because the air smelled like marijuana. And I was like, oh, holy cow, no, it was not. I went from having the ability to drink all the water I needed to having to pay $5 a bottle for water. And I didn't have the money to buy that, so I was not drinking that. And my sugar went all the way up to 1,200. So by the time I got home, and I remember I slept through most of it. I didn't see a lot of the good acts that I should have seen. Yeah, there's many more stories that aren't appropriate for TV. Just talk to me later. We'll talk about them. But when I got home, my mom kind of realized that I needed to go to the doctor right away. So I was oblivious to it. And all I remember is being passed out, sleeping in the car, going from my pediatrician's office to the hospital. And my mom said, we know you have diabetes, and just kind of crying because I was like, I'm 5 days away from turning 16 and you're going to tell me I can't have cake. That was my big thought. So, okay, now I'm off track. What were we at? Oh, okay. So we're talking about that gentleman who had a 700 blood sugar and had a heart attack, and his sister's in front of me. And she said, does that mean he has diabetes? Absolutely, he has diabetes. And she says, well, he doesn't care about his diabetes, he just cares about his heart. And if his heart is okay, he's not going to worry about the diabetes. And that broke my heart because diabetes and heart disease are so close together. And yeah, you can get a stent. Yeah, you can take a medicine to lower your cholesterol. You can do things to reduce your risk factors, but if you are not paying attention to your diabetes, you are not taking care of your heart. So there are so many people that don't recognize the two of those are associated together. So there are lots of different types of heart disease. When we talk about the ones that are associated with diabetes, the two most common are coronary artery disease, which means a blockage in the arteries, and congestive heart failure. There are many people that will have both, that may start off having blockages in their heart attacks or stents, and then will end up having heart failure. And we're also finding now that maybe there are many people that have heart failure before they know that they have blockages in their arteries. The other types of cardiovascular disease, because when we say cardiovascular, we're talking about the whole vascular system, is that stroke that we had on that last page and the peripheral artery disease. So what is diabetic heart disease? This is just, if you have diabetes and you have heart disease, you have diabetic heart disease, right? Unfortunately, as compared to people who don't have diabetes, people who have diabetes are at higher risk. They have additional causes of heart disease, which is typically our blood pressure, our cholesterol, and obesity. And also, they may develop heart disease at a younger age, and they have more severe heart disease. So I put this in here. I know I'm probably not so great for the back of the room, but this is a chart that looks at diabetes and CV. If you see CV in here, I apologize, it's cardiovascular disease. So when you look at this plot, the red line is people with diabetes who have had heart disease. The blue line is people who have had a heart attack. The gray line is people with diabetes who have not had a heart attack. And then this, I guess it's kind of green. The green line here is those who don't have diabetes or don't have heart disease. Here is the mortality risk, and here is the age. So 30s, 40s, 50s, 60s, 70s, 80s, women, men. So what you notice on this slide is if you are a person, the highest risk person of dying is those who have had diabetes and have had a heart attack, okay? Then what's important to know? Because some of you may be like, yeah, I've got diabetes, but I don't have heart disease, right? I've never had a heart attack. I don't have any blockage. You, as a person with diabetes, if you look at the curve between this gray and the blue, it is really exactly the same, right? So, and a person with diabetes, even without any established heart disease, has the same risk of death from cardiovascular disease as the person who has had a prior heart attack, right? So take your heart seriously. And then that last line you can see, of course, unfortunately, as we get older, everything increases in risk and severity. But what I also want you to look at is in that young population, that diabetes really increases the risk of dying as compared to the other ones. So a very poignant slide. And death from cardiovascular disease will claim the lives of 2 of 3 individuals with diabetes. 2 of 3. And in fact, when we look at the statistics or the most common cause of death, cardiovascular is always number 1. Diabetes is somewhere down in the top 10, but you know what? Most of those people that are in that cardiovascular section are actually not counted as having diabetes, although we know most of them do. Because diabetes is not primary, it's not the cause, the cardiovascular is the cause. Diabetes is a part of that. Okay, so how does this happen? I thought this was a good graphic to kind of take a chance to look inside our heart and look inside our arteries. So we have an individual here. We know where our heart sits. where we're listening to you. And this is a normal coronary artery, or an artery that, when we talk about coronary arteries, that means it's just traversing the heart. The heart needs blood too, right? We think about the heart as pumping out blood to the rest of the body. The heart needs blood to be able to do what it is. So we have what we call our coronary arteries. Coronary is another word for heart. So this is a nice open coronary artery with no blockage in it. So it'd be very easy, right? Everybody loved traveling around Richmond when there was no traffic, right? Easy to get through, no blockages. You can travel where you need to, no turnarounds, no predictions, no problems with predicting how to get there. When you have diabetes, that insulin resistance, that high blood sugar causes plaque in our arteries. So if you look at this picture right here, this is where we're seeing a buildup of that yellow. I guess I have a little, does it work? Not really on the TV. That yellow is that buildup of plaque. So what do you notice right off the bat has happened to that artery? Is it as easy to get through? Is as much blood getting through it? No. So when you have that narrow plaque, you're not going to get as much blood flow to the heart as you need to get to the heart. And then if we look here, there's a lot of different stages of this, right? So there's normal, early injury where you have the beginning of a plaque, advanced cholesterol plaquing or significant atherosclerosis. You can see the difference in the narrowing. And here's where you have a complete blockage. So typically what happens from this stage to this is that you get a rupture of that plaque, and then the blood starts to clot around it. Your platelets, your clotting factors form a complete blockage, and then you can see here that you have that area of muscle damage. And if the heart muscle is damaged, it cannot pump out blood to the rest of your body. So that's a brief overview about what is heart disease, and it happens more often in diabetes because high blood sugars are toxic and they cause increased amounts of plaque formation. So I also came across the stroke version, and I thought, since even though we're focusing on the heart, this is a part of that cardiovascular disease. When we have blockages in our heart, it's a vessel. We have blockages in multiple vessels. So it's not just exclusive here. It's going to be in our gut. It's going to be to our legs. It's going to be to our carotids, which flow to our brain. So if we have a yellow plaque in the carotid artery that feeds directly up to the brain, and something happens where we get a blood clot formed or kind of a plaque breaking off, it will go right up into the vessels in your brain, and it'll cause death there. So that's part of that increased risk of having a stroke or a mini stroke. So what are the symptoms? Symptoms are going to be different for everybody. And unfortunately, sometimes people have symptoms that are so mild, they may not even recognize that they're having a heart attack or stroke. Feeling tired, right? Who doesn't feel tired? But that could be a sign of a heart attack or stroke. We commonly think of that person holding their chest. That's what they do in the movies, right? When they have a heart attack, hold their chest. I'm in a play, Scrooge, this Christmas, and there's a character that has a heart attack, and that's what they tell them to do. Hold your chest, fall down. It is a common symptom, and if you are having chest pain, do not delay, because the more quickly you get attention, the more likely you're going to be able to save, because that could be your heart dying. And if your heart is dying, you need to get blood flow back to it. That's why when it happens, if you've been with anybody who's had a heart attack in the emergency room, it's go, 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 go. They're going to get you to get that vessel open up so you have heart perfusion or blood flow to your heart. You could have discomfort in your jaw, in your arm, your shoulder, down your arm, shortness of breath, sweat or feel lightheaded. You could feel like you have indigestion. And guess what? In women, it's more commonly these mild symptoms of indigestion, right? It's more commonly that they don't have the classic symptoms. So women often have what we call silent heart attacks. So kind of know if you're not feeling yourself. One, if you're a person with diabetes, you've got to check your blood sugar, and you also have to kind of consider, could this be a heart attack? Should I seek medical care? It surprises me the amount of people that come in and we'll see them, and then all of a sudden we're like, oh my gosh, you have to go to the emergency. We got to rule out that you're not having a heart attack. Stroke, sometimes it could be weakness on one side of your body, numbness, tingling. It could be confusion, trouble talking, dizziness, loss of balance, trouble walking, maybe not visually seeing well, or having a sudden severe headache. So if you have any of these symptoms, what do? Yeah, call 911, get to the hospital. Absolutely. Look at all this. I hope you have enough gifts for all these people. So question then, is diabetes our only factor to cause this? No. But there's a lot of things that come. There's multiple factors that are associated with diabetes that can cause this increased risk of cardiovascular disease. Hypertension or high blood pressure. I say dyslipidemia. I like that because as we get to the slide, there's a lot of lipid things that can happen to people with diabetes. Smoking and obesity. So these are big risk factors that we have for cardiovascular disease. So knowing that point, being that you may be an individual here with diabetes or an individual that loves somebody with diabetes, it is very important to know your ABCs. Have you ever heard this before? So ABCs in the world of diabetes stands for A, our A1C test. Who knows their A1C, their last A1C? All right, good. I'd love to see everyone's hand go up, but I know you don't all have diabetes here. Blood pressure. B stands for blood pressure, so knowing what your blood pressure is and what the control should be. C for cholesterol, knowing your cholesterol numbers and what those goals should be. And S we put in there for stop smoking, so know your ABCs. So A1C, we use it as a 3-month average of our blood sugars. Our hemoglobin A1C is the full name of it, and it really is just a chain of glucose that sits on our red blood cells. The higher your blood sugars are, the longer the chain. The more controlled your blood sugars are, the shorter the chain. So the higher the number is, the more you are, the more your sugars are uncontrolled. So when you hear someone and their A1C is 10%, their blood sugars are higher than someone's whose A1C is 7%. Okay? When we look at it, why is it a 3-month average? Well, our red blood cells in our body live for about 90 days. So that's why we look at it as it being a 3-month average. It is not the perfect test for everybody because there are different people may make the chains longer or shorter based off of things like how their body makes blood cells. So if you have anemia, you may have a shorter chain, or if you had your spleen removed, even ethnicity can play in a role to how much you can glycosylate your hemoglobin. A normal A1C is less than 5.6%. Pre-diabetes is considered to be in 5.7 to 6.4. And typically our goal for diabetes is less than 6.5 or 7%. But I will say, I thought I put this in here, each person is individualized. Some people it may be totally appropriate to have an A1C of 8% because sometimes the risk of having it too low could be low blood sugars. So I hope that with this, you don't just know what your A1C was, but you know what your goal for your A1C is. And if you don't know, ask your healthcare provider. So how can we lower our A1C? I love this cartoon. I think The Simpsons had to have been around when I was diagnosed with diabetes, but I see this every day when I'm coming into the room to see somebody and they have a good A1C, they're so excited, right? So when your A1C is lower than you thought it would be, it's an exciting time. But how can you control your diabetes? Number 1, take your medications. Number 2, if you see me, you know I harp on this, check your blood sugar. This is an amazing disease that you have something that can take a second to understand how well you're controlled. You don't get that with your heart. There's no way to say, hey heart, how am I doing? Okay, I'm good. But you get that with your diabetes. And knowing that you can control your blood sugars and reduce your risk of complications, you gotta check them. So please, if you have diabetes, check your sugar. Nutrition, which we'll get into, an active lifestyle. And I also put this in there because we actually currently have a few medications that we can prescribe that can help lower your risk of heart disease. So not just control your blood sugars, but actually lower your risk of heart disease. And this happened in 2007 or 2008. There was a diabetes medicine that was a very good diabetes medicine, but one physician did a study that thought it increased the risk of heart attacks. So when that happened, knowing that diabetes and heart disease are so strongly associated, the FDA said, you know what, we need every diabetes medicine that comes out from this point on to prove that they're safe for the heart. So as a result of doing that, we've actually found that there are a couple medicines that actually can reduce your risk of either having a death from heart disease, heart failure, or what we call, the fancy term is 3-point MACE, which means not a heart attack, a stroke, or cardiovascular death. So some of these I put up there. It's tiny to see, so it's Jardiance, Farxiga, Invokana, and Victoza, and there's many others that are coming soon. So I know that there's many other positive studies, but I just only put the ones up there that have that FDA indication to not just help with your diabetes, but also help reduce your risk from cardiovascular disease. Okay, B is for blood pressure. Now this number has gone up and down. So if you want to debate me about it, that's okay. But I say generally our goal for our blood pressure is less than 130/80. Sometimes if you have low blood pressure, you have orthostatic, if you get dizzy when you stand up, that blood pressure goal may be a little bit higher. But generally this is to help reduce the risk of complications. And this is the micro, which is our small vessels, and macrovascular, which is our large blood vessels. So it will help reduce the risk of damage to your eyes, your kidneys, to your cardiovascular system. And the ideal medications for treatment of hypertension are what we call the ACE inhibitors or the ARBs. So if you're like, well, I don't know what an ACE inhibitor or an ARB is. An ACE inhibitor is a medicine that will end in a pril. So it may be enalapril, captopril, lisinopril. Those are our ACE inhibitors. And our ARBs are medicines that end in a sartan. So like olmesartan or losartan. And some of you may be like, I don't have any of those, but sometimes they're combinations that they may be like a, or the brand name like Cozar or Hyzar. So sometimes they're actually married in with another medicine called hydrochlorothiazide, right? See, I'm just trying to sound smart again, guys. That's all I'm doing. But, look and see if you have those medicines that end in a pril or a sartan. Those are the best medicines to help protect the kidneys from diabetes. And then typically people with diabetes need about 2 to 3 medicines to control their blood pressure. So they have a little bit more treatment-resistant blood pressure. So in addition to the medicines that you have to take for your diabetes, oftentimes you have to take multiple things. So it's not just about taking a blood pressure medicine. There are other therapies that we can have that can improve blood pressure. Number 1, stop smoking. We already had that as the S, right? Smoking will increase your blood pressure and make it more treatment resistant. Exercise. Exercise is a natural way to dilate out your arteries. And if you do that, that will lower your blood pressure. Diet, decrease your salt intake. How many people will say, I don't add salt, I don't eat a lot of salt? Oh, we only have a few. Okay. I get this all the time. And, we don't, I'm happy to see that we stopped adding a lot of salt to our diet, salting things at the table. But there still is a lot of salt in the food we eat. Even the lovely salads, the turkey will have salt in it. You have to kind of consider those things. So it's a really hard thing to have a low salt diet, but it is helpful for your blood pressure. Maintaining and achieving a healthy body weight, well, that's going to help your blood sugars too. Limiting alcohol intake and controlling your blood sugar. So I put a little funny cartoon of these mosquitoes that said, I hope this is one of those people with diabetes. And it says, yeah, some of them are real sweet. So don't let those mosquitoes feed off you. Okay, so C is for cholesterol. So I love the adage of the ABCs of diabetes, but it is so much more than the total cholesterol, right? So much more. We do have goals for each number, and I said earlier, I call it dyslipidemia because we typically see with people with diabetes is that they have a high triglyceride, a low good cholesterol or HDL, and a high LDL. So it's not all hyperlipidemia because we tend to see that our good cholesterol is too low. So our general goals of the total is less than 200. That's the thing I pay the least attention to. Psht. The next is our triglycerides, which is less than 150. This is typically something that you can make a big impact on by just controlling your blood sugars and watching your dietary balance. That can improve all on its own. Some people have just bad luck in their families and have really high triglycerides. Then our LDLs are bad lipids. So I put in a little cartoon there of good cholesterol, HDL, or bad cholesterol, LDL. There is another neat way to think about it that makes it easy. HDL, good cholesterol, that's the one we want to be high, right? So if it's good, we want that level to be higher. LDL, bad cholesterol. L, we want it to be low, okay? So you don't have to necessarily remember the devil LDL cholesterol, but it is considered our bad cholesterol, and there are different variations of the goal. If you are somebody with diabetes and you're over the age of 40, absolutely, we need it to be less than 100. And everybody should be on a statin even if their LDL is below that, if you're over 40. If you have risk factors or you have established, and this is where I put that abbreviation ASCVD, which is atherosclerotic coronary vascular disease. It would have taken up a lot of the slide, that's why I shortened it for you. But that way your LDL should be less than 70. And if you have severe, like multiple vessels or the heart, you've had strokes, you've had multiple events, you had open heart surgery, there's really now the homage is kind of there's no too low LDL. So the lower we can get your LDL, the better for you. Our HDL, our good lipid, this is actually probably the hardest one to improve. For men, we want it above 40, and for women, we want it above 50. So these are kind of some goals set out for your cholesterol or your lipid panel. I don't expect you to remember all of these, but it's something to talk to your provider about what your goals could be. And then S is for stop smoking. So I know that a lot of times when we talk about smoking in general, people are kind of aware of lung risks. Lung, COPD, asthma, lung cancer. But this is another thing that I don't know that there's a strong association with that risk of cardiovascular disease. And in this picture, this is a tip from a former smoker. Diabetes and smoking is a bad combination. So he would have had what we would have called peripheral arterial disease, where his blockages were in his legs. You can also see he's got a scar here, which is a scar that we typically see after open heart or coronary bypass surgery. I will tell people that come to see me with diabetes, if they are smoking, they are lighting dynamite, because you already have that high risk of blockage, and the smoking is just going to accelerate it. So they're going to tend to have heart disease. And what would you say about this gentleman? Younger, right? He's not a spring chicken, but he's not in that higher risk of cardiovascular disease even without diabetes. So typically, if you have diabetes and you smoke, you are going to have heart disease at a very early age. So nutrition. So another way to reduce your risk of cardiovascular disease, which we've also mentioned that nutrition is going to help your blood sugars. What else did we say it was going to help? Our blood pressure and our cholesterol, right? And there's so much information out there about nutrition, right? Which is in fact why I feel lucky and blessed that I work with a set of great registered dietitians right in the office with me that can answer these questions in detail. Because usually, if we have time, it's a couple minutes to talk about it. So I like to focus on something that I think is simple, because although we think balance and carb counting is very helpful for diabetes, it's a difficult thing to do. So I like that plate method. So the plate method is looking at your 9-inch salad plate and dividing it in half, and half should be your low-calorie vegetables. Or I would say to you, non-starchy vegetables, which means anything that's not potatoes, peas, or corn, because those are more carbohydrate-based vegetables. And then if you go to the other half of the plate and you divide it in half, you get room for your starches, your carbs there. So put your potato, put your peas, put your corn there. Or if you wanted to have rice, or if you wanted to have a little bit of bread with your meal or pasta, that's where that would go. So it really, and usually, like I'd say, a cup or a fist size is about appropriate. And in protein, that's going to be that other fourth of your plate. That's where you want to put your meats, eggs, or other sources of protein from dairy. And generally, we want you to choose healthier meats like our chickens, turkey, and fish, and really limit the amount of red meat, sugary foods, and sodas. And typically, an appropriate serving of meat is about a deck of cards, right? It looks like there's a bunch of poker players out here, so I know you guys all know what cards look like. So that's about appropriate. But we kind of move away, like I feel like a part of our American diet, we've moved away from having a lot of fruits and vegetables in our diet. So having the ability to have half your plate, which is salad, is beautifully qualifying for it, because you have over half of it is your vegetables, right? And then you've got a good component of protein, and it's low fat with your turkey. So nice job. Good job with the present. I didn't say, I heard nothing about cupcakes, blah, 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 blah. So what do you need to change? What do you need to do to reduce your risk? Well, we talked about making lifestyle changes. Please take your medicines. I wish it was that easy. I wish it was that easy that I could say, here's a prescription. This is going to take care of your diabetes. You went to the pharmacy. It was cheap. You got it. You took it. You tolerated. I wish that it was that easy. I know right now probably the biggest thing that I talk about in my office every day is cost. Cost of medicines, cost of therapies, and it's heartbreaking. But don't not take something because you can't afford it. Let somebody know. We have a lot of programs out there. We have a lot of resources that we use as an office. Your physician should too. Don't just say, I can't take it, I can't afford it. The doctor should have known it. I have no idea how much that prescription is going to be. That's what I can give you. Okay. I have no idea how much that's going to be. I know I want you to be on this medicine because I want you to not die from heart disease. I have no idea how much it's going to cost. For some people, it's free. For some people, it's $400. For some people, it's $50. Some people have no problem paying for $400 medicines. Some people have problems paying for $5 medicines. Whatever you are, don't feel like you can't tell somebody that you need help, because there are lots of programs out there for you, okay? And then, of course, not just for blood sugars, blood pressure, cholesterol, activity. I say really the most effective things for diabetes and these other diseases we talked about are lifestyle. All of our studies will show your lifestyle is so important. So if you get out and you get activity, if you eat balanced, you are gonna do the most cost-effective way to help control these diseases. And when we talk about physical activity, our goal is 30 minutes 5 days of the week. It does not have to be that. If you don't go 30 minutes right now, go for 5. Go for 10 then the next week. Build yourself up. And it doesn't have to be running a marathon. It can be any type of activity. Even if you're sitting here, pedal your feet, move your arms. Those are activities, that counts. And in fact, with diabetes, to walk for 15 minutes after your meal will really help control your blood sugars. And then making small changes to your diets, and those things can make a big difference. So we talked a little bit about the annual diabetes event since we're running short on time. I won't harp on this too much, but I think it's going to be fantastic. Great experience, lots to learn. And you know what I love about diabetes, and I wish that we had more people that could reach out to other people. At this event, there are so many people, and really if you look at 10% of the population that have diabetes, if you are vocal and kind of saying, hey, I'm a person with diabetes, this was my success, this is where I struggled, you're going to touch more people. So I love events where people with diabetes are brought together. So please come, please share it with other people. They can call, take a bunch of cards. I said on my way back to work, I'm going to throw them out of my car like a ticker parade so the people of Richmond can find them. And then I also wanted to tell you that November 14th every year is World Diabetes Day. This is the birthday of the scientist that discovered insulin. And we're going to come up to 100 years in 1922, the first patient to be given insulin, which I'm so thankful for because that has helped me live 25 years of life. So you think that it's been around forever, but really just 100 years. And in fact, before insulin was found, people just had to starve if they had diabetes. That's all they could do, starve and drink. So that's the end of my presentation, and I'm supposed to ask 2 questions to give out door prizes. Okay. What day is our annual diabetes event?
November 13th.
Oh shoot, too easy. I needed hands. I want the hands. First hands. Okay, I'm gonna ask a tougher question. Okay, let's see. This is tough now. All right.
They listen well.
Give me an example of a complication of a microvascular disease from diabetes. Eyes. There we go. Okay. Give me an example of a complication of a macrovascular disease. Nope. Macro. Oh, well, I saw this hand. Stroke. Okay, so what you said, you're wrong. That's a complication from diabetes, but I use the micro, the tiny, and the macro, the big. So that's more important for me than for you. But you guys have been fantastic, honestly. Oh, questions?
Is diabetes hereditary?
So when you look at diabetes, type 2 diabetes, we call it like there are so many different genes that can cause diabetes that we can't locate one specific gene to cause it. However, if you are a person that has parents with diabetes, you are more likely to have diabetes. Yeah?
Do they have more help at Reid for people with juvenile diabetes?
Yes, I mean, I think in general, as endocrinologists, I know myself, I take 16 and up. So when we say juvenile diabetes, that's another way to say type 1 diabetes. And no matter what age, the nutrition component, the Diabetes and Nutrition Center, are there to support individuals with any type of diabetes. We've talked a lot about having different support groups for them because, again, just like I mentioned, it doesn't matter to me what the type of diabetes is. The more you can connect with others, the less you feel alone and the less that you struggle with it. So yeah, I mean, there are a lot of medical professionals that will do and take care of type 1 diabetes. We have the opportunity, even if their physician is somewhere else, for them to get training on certain diabetes technology like insulin pumps, continuous glucose monitors, how to take insulin, how to carb count. So there are a lot of availability for people with type 1 diabetes. Anyone 16 or up at Reid Endocrinology Center, we'll accept them as patients.
They didn't use it.
What's that?
They didn't used to, they couldn't.
Well, so I have actually only practiced here for 7 years. So it's still kind of a young practice. But yeah, so now we're open to that.
I just wanted to say that when they asked the question, is it hereditary?
Yeah.
And you said it's most likely in a family. I have a great-granddaughter who's just less than 1, and she was diagnosed.
Yeah. So there are a couple types. You know how we talk type 2 and type 1. You know, there is a predisposition to those when we look at heredity, but there are hereditary types of diabetes. So there are some that they're rarer. In fact, we think it's less than 5% of patients with diabetes, but it may be bigger because the world of genes is so new to medicine. So it may be bigger than that, but there are some families that will have hereditary diabetes that we can see present in very young individuals, and sometimes it can even be type 1 in that age group. But oftentimes, if there's a lot of family members, you know, their parents and then their siblings that have diabetes, sometimes that hereditary type of diabetes should be evaluated. Great questions. Yeah?
Both of my parents had it, my mom and my dad, and their family, they had 7 girls, and out of 7 girls, all 5 girls had diabetes.
Yeah. You know, and sometimes when we look at that, and there's a lot of risk factors there. We're looking at family history. We're looking at even ethnicity. You know, there are certain ethnicities that have a higher risk of having diabetes. Even if you looked at the same across different races, if you had the same body type and age, their risk of insulin resistance may be a little bit less. And oftentimes those are the type of people, that's why I ask family history. So if you were to come into me and say, oh, my mom and dad had diabetes and practically all of my siblings, then I'd be like, okay, tell me about mom's siblings and tell me about dad's siblings and how many of them had diabetes. Sometimes that genetic form, even though it's incredibly rare, gets missed. So I've had a couple people in my office who we have found them to be what we call MODI, or a more genetic type of diabetes as a result of taking a good family history. Any other questions? Oh yeah, so the question was, wouldn't that also be a learned lifestyle? And that's a big thing about nature versus nurture. But yes, a part of that is that sometimes when we have certain ways or behaviors that may put you more at risk for diabetes. So sometimes that can be the case, but sometimes it's just if you have that genetic form, you're going to get it at a young age no matter what you do. Great questions. You didn't tell me I was going to get. Do I get a prize for answering all these?
What do you attribute, because you're a doctor and you're diabetic,
Yeah.
but you seem to be handling it quite well, so what do you attribute to your...
Oh, do you want me to talk about myself? How fantastic.
Because you've done a great job.
Well, thank you. You know, one thing that I will say as being somebody with diabetes, there is no way that you're not going to struggle. You know, and I may walk and talk a good game, but I have low blood sugars and I have high blood sugars. But what I do, I've gained a lot from being able to learn through all my schooling. I've gained so much from taking care of people who have diabetes. The one thing that I think is key is to be aware of what's going on with yourself. You know, to not take anything for granted, to not think that if I ignore it, it goes away. And although that question was great, asking me how I found out about it, I, as a teenager, ignored it. You know, I thought it's going to be cured. I have no problems. And it could have been very dangerous for me had I not flipped that switch. So now what I really attribute being able to be in control is, one, I don't feel that I can be a good endocrinologist if I can't control my own diabetes. And number two, you know, I'm happy if someone comes in and their sugar is 120 and I can look at my sugar on my watch. Well, sometimes it's not up right now. And usually when I talk, I get a little bit stressful, but I can be like, oh, my sugar's 176, you win, you know? Because every day we have little different things or struggles with it. And it's about just making sure, hey, if my sugar's a little bit high, did I just eat? Am I keeping it a little high? I just ran a half marathon on Saturday. That's kind of what I do. I want to stay active. I use running as a way to take care of myself. And sometimes I say, you know what, I want my sugar to be 170 before I start this so I have enough glucose to get through it. So, yeah.
You have an insulin pump.
I do, yeah.
Talk about that briefly.
So an insulin pump is how I would deem it simply is it's an artificial pancreas. So what happens is that you use a rapid type of insulin, and this is typically if you know someone who's taking insulin or on insulin, insulin that you would take at a meal. The pump has a program to deliver insulin continuously throughout the day. So as I was talking to you, I got probably a rate of about 1 unit of insulin because it's about 1 unit an hour for me, just happening without me touching it. And when that insulin, even though it's a rapid acting insulin, when it's given slowly and continuously, it keeps your sugar stable in a background. Then the other program in here is information that the pump uses to know if my blood sugar is high, how much a unit of insulin will bring my blood sugar down. And if I'm eating carbohydrates and I tell it, right now I'm going to have 45 grams for that cupcake over there, it knows how many units of insulin I need for every gram of carbohydrate or my insulin to carb ratio. So I would just take my insulin pump, I would turn it on, and I would say, oh, okay, my sugar is 176, 45. I hit bolus, and then it delivers insulin through this tubing into a site in my body that's too low for TV, somewhere right about there. And then I change that every 3 days, and I change the insulin every 3 days. So if I did not have an insulin pump, I could still manage by taking injections at meals, but I would be taking probably 4 or 5 injections every day. This I have to change every 3 days, and it's all just on top of the skin, so nothing is implanted.
Do you manually still check your blood?
Absolutely, yep, absolutely, yep. I also am blessed to wear another piece of technology called a continuous glucose monitor. So it's not that my watch, I don't mean to like make it look like my watch is checking my blood sugar. I just can see the app on my watch of what my blood sugar is. And because my phone is way over there, I'm a little too far away from it to actually see what my blood sugar is. And it's also nice because of the risk, the fact that I told you I have highs, I have lows. It will alarm me if I'm too low. And it even can send a message to my husband, no matter where he is. If my sugar falls too low, he gets alarmed. So if he loves me, he'll call me or wake me up. Yeah, so, no, he does. Yeah, he does. Usually he wakes up better than I do at the alarms. You know, he usually wakes up a little more than I do. Okay, any other questions? No? No question? Okay. All right, so drawings, right? You guys are done with me.